In this section, we're going to discuss about non-alcoholic fatty liver disease. So non-alcoholic fatty liver disease has been there for a while and it has been studied since the 1950s. Started the prevalence, there is an increased prevalence in nations wherein there is abundance in food intake. In the US, non-alcoholic steatohepatitis is, to, is thought to occur in 3% of patients who has non-alcoholic fatty liver disease and more than 40% of which are obese. The spectrum of non-alcoholic fatty liver disease or NAFLD is from simple fatty liver steatosis progressing to non-alcoholic steatohepatitis to fibrosis and cirrhosis. This means your patient is not taking any alcohol. We have already mentioned in the past lectures that cryptogenic was the previous term that was that was used to imply non-alcoholic fatty liver disease. Here is what it looks like from the point of view of an artist, where you have a healthy liver to simple fat accumulation to non-alcoholic steatohepatitis down to cirrhosis. You will notice that the green arrows can be achieved up to non-alcoholic steatohepatitis provided you do several interventions that we may discuss in a little while. The causes of macrovesicular steatosis or accumulation of fat is secondary to insulin resistance. In here, we have centripetal obesity, wherein you have most of your patients will have type 2 diabetes mellitus. And the use of corticosteroids, estrogen, tamoxifen, and amiodarone can influence the liver in producing macrovesicular steatosis. We have mentioned that in the past, it has been observed in the US and Europe because they have plenty to eat. And in nutritional causes, starvation can also produce macrovesicular steatosis as well as protein deficiency and choline deficiency. If you have liver diseases like chronic hepatitis C, Wilson's disease, Indian childhood cirrhosis, and you underwent jejunal bypass, this may also lead later on in macrovesicular steatosis. When you do your laboratories, most patient, most patients incidentally will have an elevated liver enzymes. There may or may not have symptoms, but if the patient is symptomatic, usually fatigue or vague right upper quadrant or discomfort, right upper quadrant pain or discomfort are among the symptoms that your patient will present to you. ALT is generally higher than AST, and it is only mildly elevated in 1.5 to 2 times the upper limit. In non-alcoholic fatty liver disease, the patient can have advanced fibrosis with non-alcoholic steatohepatitis, even cirrhosis due to NASH in the setting of normal liver enzyme. This happens quite a lot, patients with NASH, and in conjunction with other metabolic abnormalities. Like for example, patient is hypertensive, insulin resistance, dyslipidemic patients, and obese patients all contributed to the development of NASH at the background of NAFLD. So therefore, NAFLD is considered the hepatic manifestation of the syndrome. Insulin resistance is the underlying link between various disorders, and abnormal ferritin level, if you are the attending physician, you see patients with fatty liver on ultrasound who came into vague right upper quadrant pain, and you ordered for ferritin levels. So when you have an abnormal ferritin levels, this may give you a clue that your patient is having insulin resistance, even though the patient is not that obese. But you have to keep in mind, non-alcoholic fatty liver, you should exclude alcoholic intake. Some patients will tell you, I only drink one shot on occasion, once or twice in 3 months, so it will not be counted as alcoholic liver disease, meaning less than 20 grams of alcohol being consumed. Even the patient is taking in alcohol can also be classified as non-alcoholic. Testing for other diseases such as Hep B, Hep C, iron studies, antitrypsin level, autoimmune serologies should be determined to rule out other causes. Blood tests like enzymes, metabolic panel should also be done, as well as imaging studies like ultrasound, CT scan or MRI, transient elastography, or magnetic resonance elastography. But even if you have patients with abnormalities, upon imaging studies, still the gold standard is liver biopsy. Imaging studies can show features of fatty liver, and liver biopsy is characterized by macrovesicular steatosis, and the histologic features of NASH are very similar to alcoholic liver disease. So therefore, if you are thinking of non-alcoholic steatohepatitis with the background of macrovesicular steatosis on biopsy, you should go back to your patient, dig into the history. If the history will tell you less than 20 grams per day, then probably this is NASH. If the patient is a male, 60 to 80 grams per day, or female, 20 to 40 grams per day alcohol consumption, then this is alcoholic liver disease. The fibrosis that occurs in NASH has a characteristic of perivenular and perisinusoidal distribution. Previously, as we have already mentioned, they say that the patient in the 1950s, when they found patients with cirrhosis, they labeled the patient as having cryptogenic cirrhosis. But in reality, if that time the testing that we do now is already available during their time, chances are they will be labeled as NASH already. So therefore, when you have this kind of patients and you are planning to treat them, there will be three components in the treatment. You have to specifically target the NAFOL related diseases and NAFOL-D associated comorbidities such as diabetes, dyslipidemia, obesity, and if there will be complications that has set in, treatment of complications should also be addressed. Upon treatment and you see patients with obesity, the mainstay would be to lose weight and to do exercises. There is a pharmacologic agent or the STAT, which is a reversible inhibitor of gastric and pancreatic lipase. This has been shown in a small decrease in body weight, but you have to talk to your patient if you're about to start him or her on orlistat. You have to caution the patient. You have to classify whether he or she is a is working or staying at home because this will you will pass out stool which is very oily, and you have to also address the insulin resistance that is involved in the mechanism of NAFLD. We have the PPAR gamma inhibitors available, or the TZDs, or the thiazolidinedione, which improves insulin sensitivity within the fat cells and the skeletal muscles. They upregulate the protein kinase activity that decreases fatty acid synthesis. You have to caution your patient in taking this because you might develop hypoglycemia in the process, but seldom do they happen. But you should always include your patient's decision whenever you are planning to treat. So the TZDs, there are two available, the PIO and the rosiglitazones. You may also use antioxidants, vitamin E. You have to give this 800 IU per day or 400 BID twice a day. And treatment of dyslipidemia or hyperlipidemia with statin type agents. They has they have been shown to improve liver enzymes, but you have also to monitor the enzymes because statins, as we all know, will increase liver enzyme SGPT or the ALT. Another available is the ursodeoxycholic acid. They were used and was observed to improve liver enzymes. The role of UDCA or ursodeoxycholic acid for fatty liver has not been definitely proven. And at present, All efforts should direct the patient in losing weight and in doing exercises. If push comes to shove and you need your patient to undergo surgical intervention, bariatric surgery is a promising procedure. Also, if there is an irreversible damage to the liver, then liver transplantation can be undertaken. And now, the present nomenclature, according to expert, this muffled is more appropriate than the previous nomenclature because we already mentioned the metabolic manifestation of NAFLD are dyslipidemia, insulin resistance. So therefore, they came up with this new nomenclature, metabolic dysfunction associated fatty liver disease. And hopefully, in the near future, we will see other advances in the medical management of NAFLD. With that, thank you for your kind attention.